Abdominal aorta angiogram, DSA
Excellent.
study.
Yes, excellent. Okay. So what is this structure? What is this? This is the, well, you just told me, right? This is the what? This is the aorta, right?
Yeah.
Yes. Okay.
Distal
so then the aorta, distal aorta. Then okay. So what is D then? Okay. Okay. Now you know the momentum has started. So D is what?
Common eyelid, right common eyelid.
Excellent. H?
This is an external eyelid. Right external eyelid. E is right internal eyelid.
Excellent. Shall we go down to J?
This is common femoral.
Excellent. I?
Inferior epigastric.
Okay, well, there's another one that comes off similar in that area. Inferior epigastric goes where? Where does the inferior epigastric artery go?
It should be medially, sir. It should be on the medial side.
So what is this one then? Where is this going? Where do you think this is going? Imagine you've got bony pelvis here. Where is this going? To what part of, what bone is it going to?
Iliac.
The eye kind of helps you. Yes, yes. So what is this?
Iliac crest.
Okay, so this is the artery also begins with an I. So it's a circumflex iliac artery. Okay. Okay. All right. So what are we left with? Okay. So let's come to B. What is B? And B comes all the way down. B has many branches. There's a branch that goes to the left upper quadrant. There's a big branch that comes down to what artery is this? What is this artery? B. And then
IMA.
Yes. So what does IMA stand for? Give me the full term.
Sorry, inferior mesenteric artery.
Excellent. Okay.
During the left middle colic and
okay. All right. So what is this?
Branches.
What is this branch then? This is going where? Where is this going to?
Sigmoid.
Okay. Or yes, sigmoid or the rectum, right?
Rectum. Right.
Okay. Right. Excellent. So we've done B. What about C?
Median sacral artery in the midline.
Yes. Yes. Now let's talk about A now, which you started off with. You want to change your answer for A? So what are these? So as I told you, you've got one here, one here, one here, one here, and they're very low down, right? So you know you've got the IMA here. You're not going to find the renal artery at the level of the inferior mesenteric artery, are you? So what are these vessels? These are paired branches. What vertebral body is at this level?
Lumbar.
Yes, excellent.
The lumbar vessel.
This is the lumbar artery. Okay. I haven't finished with you yet. So with this knowledge of anatomy, here's your case. So first of all, what is a study? So tell us what the study is, because this will give you time to think. Oh, I'm going to do one thing for you. This is normal, okay? And here's your study. Okay, so what's the study first?
So this is also an abdominal aorta angiogram.
Okay, yep.
And so these are the same view, appears to be the same view. But the problem is that the distal aorta before bifurcation, it showing some narrowing of the lumen, and even the common iliacs are also showing the narrowing lumen as compared to the normal what I have just seen before this.
Okay.
And secondly, I can see the common iliac continuing towards the to the external iliacs bilaterally, but I can't appreciate the internal iliac vessels here.
Okay.
And
all right.
Also there are multiple, I feel like collaterals have developed due to this narrowing of the lumen, distal and all this. And these are multiple collaterals that have developed due to this stricter luminal narrowing.
Okay.
So this is all I can say.
This is all. So in summary, not this is all, in summary.
So in summary, there is a mid or distal aortic syndrome.
Let's not talk about syndrome. So you said narrowing. So there is, so okay, I'm gonna talk about this a little bit later. So there is diffuse distal aortic, stenoses, occlusions, narrowing, whatever you call it, doesn't matter. Okay, so there is diffuse disease, atherosclerotic disease of the distal aorta. Okay, and you've given beautiful description of, you know, the appearance here, the common iliac artery on the left side is involved, not really sure about the right side. Before we go on, what artery is this? This one?
This one, inferior mesenteric, sir.
Okay, if that's the inferior mesenteric, which is this one then? What is this? This one?
This is above inferior mesenteric, right? Along with the lumbar vessels. This could be
right.
Gonadal vessel. Gonadal,
okay.
But it is on one side.
Okay. Just wait a second. Tell me what this is. What is this? And you see one on the other side. What artery is this?
It seems to be colic, left colic artery with branches towards the left side.
This is coming directly off the aorta?
Yeah, lumbar artery.
Oh, no. So these are the renal arteries. The renal artery, remember, this is not this patient. This is this is not the patient. This is not this patient, okay? So this is higher up. So you can see renal artery, left renal artery, right renal artery. So if this is coming off at the level or above the renal arteries, what artery is this? The superior mesenteric artery, all right?
Superior mesenteric, okay.
This is the superior mesenteric artery. The inferior mesenteric artery is coming off down here. So again, you know, anatomy. I know that this film is a bit complicated with the number of collaterals, but I'm showing you these angiograms so that you get your eye and familiar with the anatomy here. So that's great. That's fine. So just to say, this patient I should have shown you the CT first, but I thought, you know, showing the angiographic images, I think you get asked these quite a lot, would be more appropriate. I think you guys are really good at your CT. So obviously this procedure was planned based on the CT scan. You can see heavily calcified distal atherosclerotic calcification here, which you can see corresponds to what you can see here. Interventional radiologists are very versatile people, and you know, we find our way around twisty bends and manage to, you know, fit our way through things. So then this patient ended up having some stents that were put into the distal aorta and down the common iliac arteries, and now you can see a completely different result.
This is venous angiogram.
Okay.
Showing an area of narrowing along the superior pulmonary vein, right-sided superior pulmonary vein.
Let me stop you there. Okay, so again, remember my little tips on Viva. Why do you think this study is being done?
So to look for any vascular cause.
Okay, so let's take your first guess was right. So this is a pulmonary artery angiogram, so not a pulmonary vein angiogram.
Okay, sir. Okay.
Pulmonary vein angiograms, let's say, are very difficult to do. So this is a pulmonary artery angiogram.
I'm not able to make out the main trunk, and that's why I got confused.
It's okay. It's okay. That's why you're here. That's why we're showing you these.
Yes.
So let me stop. This person has had a pulmonary artery angiogram. Why do you think somebody's having a pulmonary artery angiogram?
So for to rule out pulmonary embolism.
What is the gold standard study? What is the gold standard study for ruling out a pulmonary embolism?
CT pulmonary angio.
Okay.
So CT pulmonary angiogram nowadays.
Okay.
Or
So now this person's. sorry, yes, go ahead. Go ahead.
Sir, I have sir, look for any shunting or vascular anomaly.
Okay, so this is a pulmonary artery angiogram. So just with your knowledge of pulmonary artery angiographic anatomy, tell me if you can see an abnormality.
So there is an area of there is a narrowed segment appreciated in the along the right superior pulmonary artery. That is all I can appreciate.
Okay, okay, very good. Anything else in relation to that?
So, sir, however, the branching pattern distal to it is preserved, but there is a filling defect at this level. But I cannot see any aneurysm, any early draining vein here. Or
if it's a filling defect in a pulmonary artery, what is it then?
Sir, it can be a thrombus.
Excellent.
Or from something from extrinsic compression.
Let's stick to thrombus. This is a thrombus. Okay, so this is a pulmonary artery thrombus. Okay, so now I've told you it's a pulmonary artery thrombus. Anything else? So let's just say the left lung was normal. So I'm sorry, I don't have the full view of the left pulmonary vasculature, but if you compare the branching vessels of the left compared to the right, what else can you tell me about this, Phil?
On the right, the lower lobar branching pattern is a bit reduced as compared to.
Yes. What is that? What is a term given for that? Have you heard the term oligemia?
Oligemia.
Yes. So there's right lobar oligemia. You see this large filling defect in the right pulmonary artery. So what's your diagnosis? So what is this?
So this is.
Do you know the classification of pulmonary embolism? The clinical classification? Or any classification?
So some are the sad. So some are that like saddle embolism or branch emboli, or based on the cause, like is it that some other, is it true thrombus like from or a blood clot, or is it a fat embolism?
Okay. So what you see a large pulmonary embolus that has occluded pretty much the right main pulmonary artery. Okay.
Yes, sir.
Okay. This patient had a CTPA, which shows this finding. So why do you think we're doing an angiogram? If the patient's had a CTPA, what's the intention of doing an angiogram here? So you may not know this. So intervention so pulmonary embolus, I'm talking about from an interventional radiology world, is classified as massive, submassive, and it is massive and submassive. And these are clinical classifications, so you're not going to be able to tell radiologically, but in a massive or submassive pulmonary embolus, there are strong indications for interventional radiology treatment. And we can either go and remove the clot, or we can give clot busting medication to lyse the clot. So that's why this procedure is done. So there's a massive or submassive pulmonary embolus. You can see a large embolus involving the right main pulmonary artery. And then this patient indeed went on to have a thrombectomy. And now you can see that the lobar branches are now visible. And here's the clots that have been removed. So I wouldn't have expected you to know that, but remember the pulmonary arterial anatomy and the pulmonary. Now, if you think about it, when you say pulmonary venogram, how difficult would it be to get to the pulmonary vein? So imagine where the pulmonary veins are coming from and where they're going into. So this is a pulmonary arterial angiogram. And there are a number of reasons why these are done. You gave a reasonable answer. Obviously, a filling defect, you picked that up very well, that this is a PE. Once we establish this is a pulmonary arterial angiogram, yes, they're also done in other conditions, such as, if we're embolizing a ruptured pulmonary aneurysm, or if we're embolizing a pulmonary AV malformation in conditions such as HHT or Osler-Weber-Rondeau syndrome. But what I wanted to get you at is this is the pulmonary artery angiogram. This is a normal configuration of the pulmonary artery. You can say that the pulmonary artery is a bit enlarged, but what I want you to pick out with a filling defect, which you did very well. And then obviously then I drew your attention to this oligemia. So there's this huge clot sat here that is impeding blood flow to almost 1/4 of the gas exchange apparatus in the human body. And then this is not going to be, you're not going to be expected to know this at least in the exam, but I thought I'd show you a PE on a pulmonary angiogram, because on a CT-PA, you would have got that easily. Okay?
Nice.
Good.
Yes, sir. Sir, this is the spot axial slice of the contrast enhanced CT abdomen section, in which I can see that there is aneurysmal dilatation of the abdominal aorta with the calcific foci displaced laterally and significant amount of high density retroperitoneal collection extending towards the I can see that it is surrounding the aorta and it is draped over the vertebra and the source. These are not separate from it in my provisional diagnosis. Further, I would like to see the full extent of this ruptured aortic aneurysm, impending ruptured aortic aneurysm, sir. And I would like to refer it emergency to IR section. Yes, sir.
Okay, excellent, excellent. That's beautiful. So this is a CT aortogram, CT angiogram, contrast enhanced CT of the arterial, contrast enhanced arterial phase CT of the abdomen. All of these are synonymous. You can use all of these terms. You correctly identified the abdominal aortic aneurysm, obviously, which you can see here, you took a little bit of a while, but yes, you did, and very beautifully describe this retroperitoneal hemorrhage, hematoma. So this is a ruptured abdominal aortic aneurysm. You do not need any further views, and you did very well to say that involved the IR or the vascular surgeon. So you could say urgent vascular referral is required rather than IR, or so vascular. This requires vascular referral. Not IR does not occur in every hospital. So. Very well done. Now, can I ask you a question? Did you know what this was as soon as this went up?
Yes, sir. What?
You knew what this was. As soon as the film, I displayed the film. Did you know what the answer was? You knew this is a ruptured aneurysm, right? You did.
Yes, sir.
Why didn't you say it? You should have said this is a ruptured abdominal aortic aneurysm. The features are as following, and then give your description. The examiner might not even want to listen to them. Say, right, next. You want to go through as many films as you can. I knew from you telling me that you know what the answer is. But you did very well. Okay, so this is a ruptured abdominal aortic aneurysm, and I'm just going to go through, thank you very much. I'm just going to talk a little bit about aneurysm. So an aneurysm is what? An abnormal dilatation of a vessel, and it involves all three layers of the vessel wall, and typically it is 1.5 times the normal diameter of an artery, whatever artery that is. So in the case of the abdominal aorta, anything more than 3.5 centimeters is by definition considered aneurysmal, and aneurysms are considered for repair when they reach a threshold of 5.5 centimeters. We tend not to repair aneurysms less than 5.5 centimeters due to some various trials. So anything when you are coming across one of these exams and it reaches a threshold of 5.5 centimeters, it should be considered for elective repair, because the aneurysm ruptures have a high mortality of approximately 80 to 90%, and the risk of rupture increases exponentially after a size of 5.5 centimeters. So remember this: 5.5 centimeters and above patients should have a repair of the aneurysm. When you look at an abdominal aortic aneurysm, try to describe what it looks like. I know I only gave you one axial slice, so if it's an infrarenal, suprarenal, a saccular aneurysm, or a synchronous aortoiliac aneurysm, these are important because the treatment is different for each one of these. As you said, very correctly described, this almost mirrors the case that I showed you. So features of ruptured abdominal aortic aneurysm you have usually a retroperitoneal hemorrhage. Aneurysms either rupture retroperitoneally or intraperitoneally. The intraperitoneal ruptures never make it to the hospital alive. It is usually these that you see on CT. You may have focal wall discontinuity, but you can have hemorrhage in absence of focal wall discontinuity. And very rarely will you see contrast extravasation. If you do see it, it usually occurs in the posterolateral aspect. And again, there are various other ways that these aneurysms present as a rupture. And the one that I showed you had a combination of the drape sign, so where the plane between the psoas muscle and the aneurysm is absent. And here you can see that there is a hematoma with the aneurysm intact. On a non-contrast CT, you can see this focal crescent sign. Now, this is very important in elderly patients who present with renal colic. Beware of the elderly patient renal colic who ends up having a CT KUB. Bear in mind that they could have early signs of a ruptured abdominal aortic aneurysm. So high density on a non-contrast CT is indicative with this, obviously, a retroperitoneal hematoma is consistent with ruptured aneurysm. And obviously, frank disruption is something that well, this is probably the easiest sign of them all. Endovascular aortic repair is now being offered both in the elective and emergency setting. I'm going to skip this in the interest of time. This is what an EVAR stent graft looks like. You will probably not be asked in your exam in Pakistan, but certainly the FRCR exam, you will have to have some kind of basic knowledge of EVARs. So this is what this is a stent graft. It's a stent covered in graft material, and it is inserted. And all it does is it excludes the aneurysm sac. So the blood, rather than flow into the aneurysm sac and pressurizing it, then flows down this tube graft. And then what we hope is that the aneurysm sac shrinks over time. I'll skip the steps. And again, I'm going to skip this video as well. Here's a video of a ruptured aneurysm. This is how an EVAR is done. So again, there was a question a couple of days ago in one of the groups about DSA. So this is the digital subtraction angiogram of the abdominal aorta, or an aortic angiogram, whatever term you wish to use. So you can see the aneurysm here. The stent graft has now been deployed, and this is the final angiogram, and you can see the contrast flowing through the graft. The aneurysm is no longer visible.
I'm provided with the 2 spot images from an antegrade pyelogram study, in which I can appreciate that there is a stent inside the renal pelvis with the specification of the renal pelvic glacial system, and up to the middle third of the ureter is opacified. However, no distal passage of contrast is seen. I'm unable to appreciate any filling defect within this renal pelvis and galluses. However, there is a small outpouching from the upper pole right renal pelvis, which is filled up with contrast, and there is some pooling of contrast within it. No evidence of any leakage or any extravasation of contrast noted.
Right. What has been done to this patient?
Sorry, sir?
What procedure is this? What procedure is this?
Hence,
I'm an interventional radiologist. What has been done? Okay, or another word, how has this been done then?
So stent has been passed, nephrostomy has been done.
That's what I wanted to ask you. So these are bilateral nephrostomies, okay? And obviously, yes, you gave all the findings correctly. You see contrast here, you can't see it. But obviously, you would ask for further views, right? Or further films. Yes. So this is not an IVU or anything like that. These are bilateral nephrostomy tubes. So not stents, bilateral nephrostomy tubes. And what are these? These are simply a pigtail catheter, like you would for your acidic drain, like you would for your pleural drain. That's all it is. A nephrostomy is simply a pigtail catheter put into the pelvic glacial system. What is the age of this patient? Roughly. My age or somebody's children's age?
So some young patient, pediatric age group.
Okay, excellent. Okay, excellent. So well done. Okay, so I wanted to bring to your attention bilateral nephrostomies. How are these done? The calyces, the minor calyces are accessed either under ultrasound or fluoroscopic guidance with a needle. Guide wires are inserted, and then bilateral nephrostomy tubes are then eventually put in. This was I think an 8-year-old child with bilateral hydronephrosis from this obstructing abdominal mass. This was a rhabdomyosarcoma, not based on the imaging findings, obviously, because I did the nephrostomy and then I ended up doing a biopsy for this patient. So the indications for a nephrostomy are 3. 1, to relieve urinary obstruction. You want to preserve the renal function and treat urosepsis. Number 2, urinary diversion. So if there's an injury of the urinary tract distally, typically our gynecologists and even our colorectal surgeons can injure the ureter in pelvic surgery, and hence nephrostomies are inserted to divert urine away from any area of fistula or tract to allow it to heal. And finally, a nephrostomy is the first step for either doing a PCNL or for putting in a ureteric stent.
Okay, I'm provided with spot image of cholangiogram, which is likely percutaneous cholangiogram. And on the given images, I'm able to appreciate that there appears to be dilated intrahepatic biliary channels with some stenosis and irregular dilatation, and no outline of the opacification of the extrahepatic biliary channels is noted, along with no opacification of the gallbladder. The cutoff is likely at the level of the right and left biliary tract confluence. So I will correlate with the history of any surgical intervention to rule out any ligature injury.
Okay.
And the other possibility, since it is quite clear cutoff, not irregular. So I think this is likely a benign cutoff. And on the next images, is this of the same patient, sir?
Of course it is.
Okay.
You're doing very well, by the way. Yep.
Right. So this is other images. In these images, again, right and left biliary tracts are dilated with the again the abrupt cutoff level. So no passage. I think contrast is outlined in the bowel.
Okay.
This might be due to stenting. This might be due to stenting because I can't appreciate the clear margins of the CBD or cystic duct. But on the other hand, if it was a post-op case, this might I might be able to appreciate any T-tube, which usually we have in the post.
So there's no history of surgery. No history of surgery.
Right. So this abrupt cutoff could be due to some malignant mass or some extrinsic compression from the mass, which has caused this abrupt cutoff, since there is no history of surgery.
What malignant mass is
likely, sir? Cholangiocarcinoma would be my provisional diagnosis. And differential could be some hepatic malignancy, which might be compressing at this level and causing the stenosis.
Okay. All right. Excellent. Okay. Excellent. So what is this study? What study is this? What has been done here?
So that's the PTC, percutaneous transhepatic cholangiogram.
Excellent. That's what I wanted to ask you. Percutaneous transhepatic cholangiogram and a guide wire and catheter were eventually crossed. So the stricture was crossed here, and that's why you see opacification of the bowel. And then this is an internal external biliary drain.
Right.
Okay, this has been placed here into, so in PTC, you opacify, you do a cholangiogram, percutaneous transhepatic cholangiogram. That's what you saw on the first 3 images.
Right, sir.
Then you identify the problem. So there was a stricture there. The stricture was then crossed in the picture on the right. An internal
Right.
external biliary drain was inserted. So this almost looks like a nephrostomy tube. There's a pigtail here. There's some side holes here, and there's some side holes here. So then all the bile drains into these side holes and then comes out through here. And then finally, this is what a stent looks like. So, you're the second person who said, stent, when actually there's a pigtail catheter. So this is a pigtail catheter, and this is what a stent, or at least one of the stents, look like. This is a metallic stent, as opposed to an ERCP stent. So this was a metallic stent put in for a malignant stricture. You did very well. And here's a CT scan. And as you can see, there is a dilated intrahepatic bile ducts, and there's a central area of ill-defined hypodensity. This indeed was a cholangiocarcinoma.
Right.
Okay, I'm just going to talk a little bit here. So again, I'm mindful that this is a mock session, but also I want to talk a little bit about, I think it's important to understand a little bit about interventional radiology when we're talking about vascular imaging, because you may see pre-interventional radiology imaging and post-interventional radiology imaging. And I'm going to focus on one aspect. So hemorrhage control, one of the roles of interventional radiology is to stop bleeding. These are the four commonest causes of bleeding: GI, trauma-related, iatrogenic, and pseudoaneurysms. And these, by and large, are treated with a procedure called embolization. What is embolization? So again, this is not going to be in your exam, but I'm just trying to sort of make you understand a little bit about vascular interventional radiology while we're here. Embolization is the deliberate introduction of an occlusive material into a blood vessel, in this case, in order to reduce or obstruct the blood flow. Basically, we put something into a bleeding blood vessel to stop it from bleeding. There are many embolic agents that we use. We have something called particles, okay, and they come in a variety of sizes. We mix them with contrast because they're not radiopaque. And here's a large neuroendocrine tumor, liver metastasis. You do not see segmental liver arteries like this. These are very, very huge, and this is because it's a hypervascular neuroendocrine tumor. So this is a selective angiogram of, let's say, some of maybe the segment 7, 8 branches of the right hepatic artery. These were then embolized with the particles I've just shown you on the previous page, and this is the final result. You can see that the tumor is completely devascularized and the vessels are preserved. And on follow-up CT scan, this indeed shrunk with time. So this is the principle of chemoembolization, bland embolization for liver tumors. Okay, here's another patient. So this patient has, this is an arterial and portal venous phase CT. You can see high density here within the stomach. This was a woman in her late 20s. She had a bleeding gastric tumor. As you can see, there's thickening of the stomach here with blood. Embolization has been done with coils. This is the left gastric artery. And you can see this big blush here, which is consistent with her hypervascular tumor. And this was embolized with, again, those small particles. So we started off with a tumor blush like this. Injecting those particles, you do not see any residual tumor blush. So this is another way of stopping bleeding. I'm going to skip onyx because it's a little bit specialized for this audience. Coils. Coils, you need to recognize what coils look like on plain films. Coils cause thrombogenesis within a vessel, and giving a very simplified version. They can be covered in these fibers to promote thrombogenesis. Here's a patient who's had a GI bleed. This is the arterial phase CT. And as you can see that on the portal venous phase CT, the blush becomes more diffuse. And this is a sign of active arterial hemorrhage. I'll come to this a little bit later. And you can see this on the sagittal view, the arterial phase CT here. And on the portal venous phase, you can see this arterial blush has now spread out further.